All right, so topic du jour of tonight is the sugar disease, or DKA. So we actually, this one I picked based off of a patient that we had in our ED that had come in DKA and kind of escalated through a couple of different of the basic pieces that we'll talk about, ended up getting intubated and needing some vent management. And it just seemed like a really good topic to be able to talk about because we sometimes can see DKA on a frequent basis, but we very rarely see them intubated and have to do vent management. This is just going to do a nice little review of the basics of it and then talk a little bit more about the treatment and what some options are. So going through the basics of what DKA is. So DKA is essentially just a serious complication of diabetes, can be life-threatening, and it's most commonly seen in your type 1 diabetics. It results from a shortage of insulin in the body. So you can see here how insulin normally plays a key role in helping the sugar enter into the cells, right? So it's kind of like that key to let the glucose right into the cell. So without having enough insulin, your body actually can't use the glucose that's circulating in your system anymore for fuel. So now it has to use fat for fuel. And when you start using fat for fuel, you produce a buildup of acids in the bloodstream that's called ketones, which eventually leads to DKA if untreated. So if we go a little bit deeper into that physiology, we know that DKA arises because of a lack of insulin in the body, right? And so that leads to that high amount of glucose in the intravascular space, but that means that there's a low amount of glucose within the cell, right? Because the insulin isn't there to let the glucose in. So that high glucose in the extracellular space starts to spill out into the urine. When it does, it takes water and solutes such as sodium and potassium along with it. And that's a process called osmotic diuresis, right? So it kind of almost flushes out a lot of the good stuff out of your system. And that's what causes that increased thirst, increased urine output, and the dehydration that we're going to talk about in a little bit. The absence of the insulin also leads to a release of fatty acids, which is converted to ketones. And so the ketones make the blood acidic. So it puts that person into that metabolic acidosis. And so the body tries to start to buffer this acidosis by using bicarb, through the kidneys. So we use our bicarb buffering system. So the system gets quickly overwhelmed. And so then you have other mechanisms that try to help compensate for the acidosis. And one of those mechanisms is hyperventilation. Because with hyperventilation, we want to lower the CO2 level. So the more you breathe, the more you blow off that CO2, right? And so then that can help sometimes with the acidosis as well. So at this point, your body is doing everything that it can to try and fix that acidosis, but it's not going to work until you start getting that glucose back into the cell so that normal processes can start up again. So that's why treatment so early is so important. And we're going to talk a little bit more about ABGs and some of the lab values and things like that that we see in later slides. But this is kind of the basic overview of what DKA is actually doing in the body. And there's a couple of different classifications. So we've got 3 major stages. You've got your mild, your moderate, and your severe DKA. And when you look at this graph, you can see that there are definitely differences between the 3, and they obviously progressively get worse, right? That's why you call it severe. Severe is the worst. Blood sugar is clearly elevated in all 3, but the degree of acidosis, some of the compensatory mechanisms, and your mental status are the main components that are going to differentiate the stages. So you can see here, we've got that high glucose. That's great. Our pH. All right, so our pH steadily gets worse the worse DKA is. Our bicarb steadily drops and gets worse the worse DKA is. And we'll talk about that and why that happens a little bit later. You've got ketones throughout, regardless of what stage you're in. Your anion gap progressively gets worse. We'll talk about that a little bit later. And then your mental status. So this is the big one. When you've got a patient that's in severe DKA, sometimes the first thing that you notice or see is that they're very stuporous, or they're really lethargic, or they're obtunded. And that's your very first clue that there's something going on. Then you start to investigate and you find out, oh, they have a history of type 1 diabetes. Or you check their blood sugars, because what do we do in any patient that has a GCS of less than 15? We check their blood sugar. Regardless of what else is going on, we always want to check their blood sugar. So those are the major things that you're going to see the differences with between these stages. And mental status for me was always a big one. Okay, so what triggers a person to go from, I have type 1 diabetes, but I'm doing well and I have no issues, to I'm in full-blown DKA? Well, there's often a particular underlying problem that led to the DKA episode. It is really common that there's some type of illness that predates the DKA episode. So whether they have pneumonia, a GI bug, a UTI, there are certain medications. So somebody has to go on steroids that can actively put a patient at higher risk for developing DKA if they're a type 1 diabetic. Or if they have inadequate insulin administration. Let's say insulin is really expensive. I know we've seen a lot on the news about how much insulin costs. It is very expensive. So if somebody can't afford to buy their insulin regularly, I've had patients before where they try to ration their insulin. They know that they need to take, say, 8 units, but instead they take 4 because they know that if they take 8, they're not going to have any to be able to take later on in the day. So they try to ration themselves. And so all of these things can potentially cause somebody to go into DKA because these are things that can either cause an elevation in the glucose or it can cause a lack of insulin. In pediatric patients, a lot of times kids are diagnosed with type 1 diabetes because they have a DKA episode. So you might hear a parent bring a kid into the ED, or say you pre-hospitally, you go and you pick up a young child, 6, 7, 8, sometimes up to 11 years old, and parents say, listen, they've been really tired lately. They're drinking a lot. They're peeing a lot. They had a GI bug last week. It was going through school. They've been really tired. I don't really know. It's kind of more than their usual sickness. And you check a sugar and you find out it's elevated. And then you go through the whole workup that we're going to talk about in a little bit. And you find out that they're in DKA and they're actually a type 1 diabetic and they just didn't know it. So there are definitely a couple of things, and most type 1 diabetics, especially as they get older, get really good about sensing when something like this is going to happen. So when they know that they're sick, they can keep a closer eye on their blood sugars and different pieces like that. So what symptoms do we expect to see from these patients? So there's a lot of things that we might see. So the symptoms of an episode of DKA usually evolve over a period of about 24 hours. The predominant symptoms are nausea and vomiting. They have pronounced thirst, which is polydipsia, excessive urine production, which is polyuria, and abdominal pain that can be pretty severe and uncomfortable. And in severe DKA, you can see breathing becoming rapid and deep, which is also known as Kussmaul's respirations. A person's breath might also develop this really fruity smell if you're standing near them. Now, of course, in COVID days, we all have masks on, so it can be really hard to tell that one. But back in the day, before we were wearing masks with every interaction, you could definitely smell a really fruity smell coming from somebody if they were in DKA. It can also be confusion, lethargy, and unresponsiveness seen in severe cases, kind of like we talked about earlier in that severe DKA portion. And when you do a physical exam, there's usually some kind of clinical evidence of dehydration, whether that be dry mouth, they might have decreased skin turgor. If it's profound enough to cause a decrease in the circulating blood volume, you can actually have a rapid heart rate and a low blood pressure on your monitor when you do your first set of vitals. So this picture really kind of nicely captures what the majority of the symptoms are for a patient that's in DKA. And then how do we actually diagnose it? I've heard a lot of people, and I remember working in the ED, I'd see a high blood sugar and I'd think, okay, they must have DKA, right? But it's not just the high blood sugar, right? There's more components than that. So there's 3 major pieces that we kind of have to hit on in order to be able to definitively say, yes, this patient is in DKA. So that combination is hyperglycemia, so high blood sugars, ketones in the blood or in the urine, and acidosis. All right, so hyperglycemia can be seen with a finger stick. That's what we most commonly do, but sometimes levels can be so elevated that they're not recording on the glucometer, because a lot of machines max at about 500. So you might check a blood sugar and it just is out of range, or too high to measure, whatever it is that the phrase is that pops up on the machine. So okay, it's really, really high because it's not even able to read it. So now I might need to get a BMP or a CMP to be able to get an actual number. Does that mean that you can't treat the patient? No, not at all. It's high based off of that finger stick that says it's too high to calculate. But you also want to be able to get a real number, because when we start treating, we don't want that number to drop too quickly. So CMP or a BMP might be helpful there. But what we're looking for is a blood sugar of over 250. Okay, and then that'll check that box for this diagnostic indicator. Ketones. Ketones can be measured in the urine or in the blood. Urine tends to be the fastest because we can do a urine dip. You can quickly see, do I have ketones, yes or no? You can also send it in your blood sample. So positive urine or serum ketones will check the box for this component. And then a pH measurement is performed to detect acidosis, and a pH of less than 7.3 is kind of that final checkbox to say, yep, we're in a DKA situation. And you'll also see if you get a gas that you've got a lower bicarb as well, and you're going to see metabolic derangement. And we'll talk about ABGs and metabolic derangement in a little bit. But those are the main pieces that you're looking for clinically in conjunction with the assessment that you did that kind of triggered you into this as a potential diagnosis for this patient. Okay, so talking a little bit about ABGs. We'll just do a quick review. So there are a lot of pieces of an ABG that can kind of help with your DKA diagnosis and your treatment and management. So when you look at this equation, it helps to understand what the compensatory mechanisms are and how they work in our body to keep the pH in a normal range. So you can see here on the left, we've got CO2 and we have water. And then we've got carbonic acid in the middle. And then on the right, you can see we've got bicarb and hydrogen ions. Okay, so on the left, this is primarily regulated by the lungs, okay? On the right, this is primarily regulated by the kidneys. Carbonic acid, it's pretty weak and it doesn't like to stay carbonic acid for very long. So it likes to shift between the two pretty quickly, okay? So what does that actually mean? Well, our lungs work pretty quick, right? We can change our respiratory rate very rapidly. I mean, I could just start hyperventilating now, or I could really slow my respiratory rate and change my level of my PCO2 pretty easily. Our kidneys, though, take a little bit longer of a time to catch up. So it can be a couple of days where our kidneys are trying to start to help to compensate, but it takes them longer. It's not as instantaneous as our respiratory system and our lungs. So this is an important equation to understand, because as we get a little bit further and we start talking more about bicarb and using potentially bicarb, you can see that if you use something that's quickly going to turn into something else, it can potentially lead us to problems. We're going to talk about that in a little bit more depth in a bit, but this is an important equation to know and understand. And then talking about what normal values are on an ABG. So a pH between 7.35 and 7.45 is considered normal. PCO2 is 35 to 45 and a bicarb of 22 to 26. So when we look at a DKA patient, we're going to look at an example next. We expect to see a lower pH, right? Because we remember pH of less than 7.3 is one of our diagnostic indicators saying like, yep, we got DKA. So we'd expect to see that, but we also expect to see a low bicarb. Why is that? Well, here's an example of a patient that we have. So you can see this patient's on room air because their FiO2 is 21%. All right, their pH is 7.15, which means that they're acidotic because it's less than that 7.35, and the normal range is 7.35 to 7.45. So when we're low, we're acidotic. All right, their PO2 is 115, which is fine. That's normal for a person that's on room air. Their PCO2 is 20, which is below the normal 35 to 45 range, right? So that number's low. And their bicarb is also low. It's only 8. The normal is, remember, 22 to 26. So that's really low. And then we also have the space excess of -16. So what does all of that mean when we put it together? So DKA is essentially an inability to utilize fuel properly, right? So if the body can't utilize the sugar as fuel because of the lack of insulin, the body starts to use that fat as fuel. That creates the ketones, that creates the acidotic environment. So then your body tries to compensate by using bicarb to balance out this acidosis. And then when it doesn't work, the body starts to increase the respiratory rate to blow off the excess CO2 to try to bring the acidosis down as well. So that's why in really sick DKA patients, you'll see a bicarb in the single digits because the kidneys have been giving up as much as they can to try and improve the situation. And the body can only make so much bicarb in a short period of time. The CO2 is also low because it's trying to blow off as much acid as possible, and CO2 is an acid. So between those two things, you see the bicarb's low because it's trying to dump as much base into the system as possible. So that number's low, but your CO2 is low because your body's trying to blow off all the extra acid. It's doing everything it can to limit the amount of acid in the system. And then what does base excess tell you? Well, Normal is -2 to +2. And it essentially tells you how much base or acid needs to be added or removed to get the body back to homeostasis. So the long and the short of it with base excess is if you've got a number in the double digits, you've got a big problem. And it's usually a metabolic problem in origin. And you've got a little bit of investigating to do to figure out what it is that's causing that metabolic derangement. And then anion gap is something you hear a lot about with DKA. So an anion gap is the measurement of the acid-base balance. So your body maintains balance by holding on to or releasing CO2 through the lungs, right? That's the acid, or bicarb through the kidneys, which is the base, kind of like what we just talked about. Now, cations are positive, those are your base, and anions are negative, that's your acid. So the anion gap is the difference between the number of cations versus the number of anions, so the positives and the negatives. Normal is about 4 to 10. But when you have a patient with DKA, they're going to be typically above 12, and that's considered a high anion gap. And in a high anion gap, it indicates the presence of more anions than cations, so more negatives than positives, which is an acidosis, right? So when your bicarb is being used up to correct that acid-base balance, that gap widens because you can see you've got bicarb here. So if this number drops and lowers, and this number staying about the same, and this number staying about the same, then you can see that this gap would widen, right? And so as we start having that widening, it's showing us that we've got a worsening metabolic and acid-based derangement. Now remember, if you're calculating an anion gap using a BMP, let's say you haven't had a gas yet or you don't have access to your ABG information, you can actually use the total CO2 that's on the BNP, and it's essentially equivalent to the bicarb that comes off your arterial gas. So if you look at an actual, you look at a BMP, you can see that there's one that'll say total CO2, and that should correspond with what you see on your bicarb on your ABG. So that's just kind of like a quick hint way of doing it if you don't have access to your ABG results. And the equation really helps us more in the long-term management of the patient and helps us to really define when we've started to improve that derangement, and is a really good way of helping us to know when we can transition from, say, continuous insulin infusion back to subcutaneous insulin. And what you'll hear is people will say the gap closed, and that just indicates that the patient's condition has improved and is getting back to somewhat normal. And how do we actually get them back to that somewhat normal? What are our treatment options? Well, the main aims of treatment in DKA are replacing the lost fluids, replacing the electrolytes, and suppressing the high blood sugars and ketone production with insulin. So where do we start? Usually the easiest place to start is giving fluids, right? So the amount of fluid replaced depends on the estimated degree of dehydration. If your dehydration is so severe that it causes shock, so you've got severely decreased blood pressure, insufficient blood supply to body's organs, or you have a depressed level of consciousness, then a more rapid infusion is recommended to restore circulating volume. So that kind of like normal resuscitation that we would do for a patient that's showing signs of severe dehydration, right? Slower rehydration can be possible if the dehydration is just moderate. So maybe if we're in the mild to moderate stage of DKA where we say, okay, our mucous membranes are still a little moist and they just started feeling crummy a little earlier today and my blood pressure is normal, maybe I can just start them on a pretty decent maintenance rate and not necessarily have to give lots of boluses of fluid. And we want to make sure that we reassess the patient after every fluid bolus, right? Is it working? Is it doing what we're expecting it to do? Do we think we need to do more? Are we good with what we just did? And providers and guidelines can definitely vary on what type of fluid to use, whether saline or LR, and also about how much. So there's concerns in DKA around fluid administration and cerebral edema. And so you want to frequently make sure that you are monitoring your patient, you're reassessing your patient, and you're following either your local or hospital protocol for fluid resuscitation. Because this is definitely a time where we want to make sure that we provide and resuscitate for that patient, but we don't want to do it too aggressively that we cause worsening symptoms someplace else. And then insulin, right? So the goal here is to lower blood sugar outside of the cell, help it get back into the cell, but we don't want that to happen too quickly, okay? So that's why it's not widely recommended to give boluses of insulin anymore. It used to be that you'd give, say, about like 10 units as a bolus, and then you would start them on an infusion. And they've really recommended to stay away from that. I think there's still some, policies, some protocols, some providers that do bolus in different types of situations, but most wide DKA policies now don't encourage a bolus at the beginning and actually just have you go right into an infusion. And it's usually 0.1 units per kilo per hour. Again, check with whatever hospital or protocol that you use. But what this does is it helps to reduce the blood sugars and suppress that ketone production, right? Because if we can use the insulin as the key to get the sugar back into the cell, we don't need to then use fat as fuel because we have sugar as fuel. So our ketone production should go down. And that's the goal. But again, we don't want to do anything too quickly because it does cause shifts with a lot of different things. And we're going to talk about potassium next. And so we just want to make sure that this is a gentle process so that we get the patient back to a normal state, not too aggressively. We need to monitor blood sugars really closely. And when you're doing this, a lot of times there's going to be an algorithm with your protocol that tells you when you either titrate your insulin infusion or more often, when you change your fluids to start adding dextrose so that you don't drop your glucose rate too quickly. So those are something that you really want to look at within your own practice, your own hospital or protocols to assess what that may be. And when we check insulin, when we check blood sugars, we want to make sure that we're monitoring it fairly frequently. So that might be even every 15 minutes for the first little bit to make sure that we don't have too big of a decrease, or every 30 minutes. So it can be pretty time intensive. But before we start insulin, we want to check a potassium. So let's talk about potassium and DKA. So potassium levels can fluctuate pretty severely during the treatment of DKA because potassium likes to follow insulin. So when you give insulin and it goes into the cell and unlocks the cell and lets the glucose in, right? Potassium wants to follow along. So this means that the circulating potassium that's outside of the cell starts to shift into the cell. Okay, so that reduces the amount of circulating potassium in the bloodstream, which causes hypokalemia. And hypokalemia increases the risk of irregularities in your heart rate and your heart rhythm. So that means before we start insulin, we want to make sure we check potassium. And if that serum potassium is less than 5, then we want to add potassium to the maintenance fluids to make sure that we don't have a big drop when we start our insulin that could potentially cause cardiac arrhythmias. And that's another reason, or a big reason, why we want to have our DKA patients on cardiac monitoring. They're very sick to begin with, so we should have them on cardiac monitoring, right? We know that they can have blood pressure derangements, they can have heart rate derangements depending on their level of dehydration, but they can also have cardiac abnormalities from the potassium. So we really want to make sure that we check that potassium before we start the insulin. And again, if not, here's a really nice chart of roughly how much you need to give the patient to get them back into a normal range so that you can actually start the insulin. And 3.5 to 5 is a normal range for potassium. But again, giving insulin is going to encourage potassium to go into the cell. So if you start at 3.5 to 5, you know that it's going to drop. And so that's why they really want to buff people up and get their potassium a little bit on the higher side of greater than 5. So that way, when we do start giving that insulin and we do drop the potassium with that insulin, we've got that buffer space and we're still safe. Okay, so bicarb. I don't know if I've talked about it with this group yet, but I have a lot of thoughts about bicarb. So we talked about how bicarb is low in DKA patients, right? And it's because the kidneys are giving up all of the bicarb, or that base that they have, to try to make this acidotic situation better. So it would make sense to give bicarb then, right, to fix that acidosis. No. And why is that? So when we give external bicarb, it converts fairly quickly. And here's another copy of that same equation that we looked at. So that bicarb converts fairly quickly across CO2 and water. Okay, now CO2 we know is acidotic because our body's trying to blow off as much CO2 as possible to reduce the acidosis. So when we give bicarb and it quickly converts to CO2, that can actually worsen our acidosis, right? We think we're adding base, but because that base gets translated so quickly into an acid, we end up just adding acid. So you can imagine if a patient's breathing at 50, 60 times a minute, right? They're trying to blow off as much CO2 as possible. Then we give them a little bit of bicarb that transitions to CO2. That might be just enough to overwhelm their compensatory mechanism so that they can't continue to blow off all this extra bicarb. Now that pH starts to fall, it gets even worse. So administration of bicarb is definitely a hot topic amongst providers when it comes to who's pro, who's against. You know, I had a patient one time that was in DKA, and we went to go pick her up, and she had a bicarb of 1. She had a pH of 6.8 maybe, and her PCO2 was about 18. And she was non-intubated, and we recognized that with a bicarb of 1, her body needed some help. And when you give external bicarb, some of it will definitely say bicarb. But we knew that if we gave bicarb and we started to build that number up, enough of it was going to turn into CO2 that could potentially make the problem worse. And I was working with a phenomenal flight paramedic at the time, and one of the most brilliant people I've ever worked with. And he was able to intubate this patient in about a second and a half and started her vent settings, which we're going to talk about in a little bit. Extremely high minute ventilation. And so that we were able to blow off even more CO2 so that we could safely give bicarb. So the point of that story is that it's not benign. It's something that we traditionally seem to use in codes, 5, 10, 15 years ago on a regular basis to say patient's acidotic, just give them an bicarb and it'll fix the acidosis. But it doesn't. It can temporarily improve some part of the problem, but then it's going to make it worse when it starts to transition to CO2. So just be very cautious, have that good conversation with the provider and recognize that if we worsen our pH, most suppressors stop working once our pH gets below 7.1. And that includes epi when we're doing cardiac arrest. They become significantly less effective the worse that the pH gets. So we really just want to set ourselves up for success. We don't need to give sodium bicarb because their bicarb is, 8, 9, 10 higher. Then maybe we should do a risk benefit analysis at that point to see if it's something that really needs to be done. And if it does, then we really need to make sure that we have our ventilation at a good place so that we blow off whatever excess CO2 we may end up contributing to this problem.
Danielle, quick question on that.
Yeah.
Pre-hospitally, when we don't have, access to those labs and stuff, is there a time that you would kind of recommend giving it or withholding it? I know you said it's kind of in its infancy as to people, going right or left on this, but do you have any recommendations on that for people that, are pre-hospitally?
Yeah, so I would say unless you know why you're giving the bicarb, I would hold off. So like if you don't have those numbers to be able to support needing to give it, I would really focus on making sure that their ventilation and their respiratory status stays the way that it is. And if that means that they're breathing at 50, 60 times a minute and you're just helping to support that, and then doing the fluid resuscitation is really important, especially pre-hospitally. But when it comes to insulin and bicarb and all of those pieces, unless your protocol says specifically give this, if that, then I would be hesitant to push it on somebody, especially somebody that's in DKA, because like I said, if they're already breathing at 60 times a minute, they might not be able to increase that rate anymore. And if we give them bicarb and we end up increasing their PCO2 by doing that bicarb, and they can no longer support that compensatory mechanism of breathing at 60 times a minute, it does put you in a pretty sticky spot.
Perfect.
If it were me, I would definitely hold off until I had a really good reason to say, yep, nope, I need to do bicarb because the bicarb's so low or X, Y, and Z. But it shouldn't necessarily be a factor in that really acute beginning phase. That's something more I would expect to see when somebody's been in the ED now for a little while, getting transitioned to the ICU. ICU is now trying to fix this anion gap, improve the acidosis, kind of do more of that long-term management. So it shouldn't be something that you should have to encounter in that initial acute phase when you go pick somebody up.
Sure. Perfect.
And then do you intubate, right? So again, this is a Danielleism, but no. So a patient's body is its own best compensatory mechanism. And we've already talked about how they might be breathing at 40, 50, 60 times a minute. And while that might look really bad, especially if their mentation is poor, they're blowing off so much CO2 to help to compensate for that massive metabolic acidosis that is going on. And when we intubate them, we temporarily take away that drive, right? Because most of the time, now there's a couple of different intubation techniques, obviously. You can do RSI, where you're giving an induction agent and a paralytic. You can do delayed sequence intubation, where you do your induction agent, wait a little bit, maybe or maybe not do the paralytic. You can do, a no paralytic intubation, which can be really tricky because you never know with these people, if they start vomiting, then that's going to cause another type of problem that you don't want to be in. So there's a couple of different things that you could do, but at some point you're taking away their drive, even if it's for a short period of time. And so it's not uncommon for somebody that's in a severe DKA to go into cardiac arrest after an RSI, especially if you use something long lasting like rocuronium that's going to be in their system for, say, 20 to 40 minutes. And you set your ven up for a normal patient and not a really sick, metabolically deranged, acidotic patient. So if you can, I say just don't do it. Support that ventilation and that airway and their oxygenation and all of that the best that you can. Obviously, we'll talk about the next slide. What if I don't have a choice? So what does that actually mean? I mean, is there another way to support them? While their mentation is really poor and you question, can they manage their own airway? Could you support their airway with NPAs? Is there something else that you can do positioning wise? Do they have secretions where they're not managing their secretions, or are they dry enough where they're able to actually have decent air exchange? Definitely use your best judgment on these patients, but a lot of times there's tricks that you can do to not have to intubate them. But if you find you're in a situation where you absolutely are like, I'm shoved against a wall and I don't have an option and I have to intubate this person, keep a couple of things in mind. Your paralytic choice. So the two most common that we see are succinylcholine and rocuronium. Succinylcholine takes about 30-45 seconds to start to begin. You see the fasciculations where you almost see the shaking and the muscular twitching. And then it lasts about 3 to 5 minutes as a paralytic. Rocuronium takes about 1 minute to 2 minutes to get into the system, does not have the defasciculations, and lasts about 20 to 45 minutes, depending on the person's metabolic system. So that means that when you push this paralytic, from the time that you push it till roughly the time that it would end, depending on which medication you give, whether it's the short or the long acting, you are in complete control of their respiratory rate. Keeping in mind that these patients, if you pause their respiratory drive for 10, 15, 30 seconds, it can cause a buildup of CO2 so quickly and an acidosis worsening so quickly that that's where your post-RSI cardiac arrests come in. So what we want to make sure that we do is be aware of what paralytic that we're using so that we can make sure that we appropriately support the patient after the intubation is done. So a slow respiratory rate, even for the 3 to 5 minutes until the paralytic wears off and the patient's able to breathe on their own again, can be long enough to cause that cardiac arrest. Now, keep in mind when you have somebody that, say you use succinylcholine, you intubate them, then their natural respiratory drive tries to kick back up again to the 40, 50, 60, right? It's going to make the vent alarm like crazy, because it's going to be a really high minute ventilation. There could potentially be high pressures because they're trying to pull against the vent and pull more than they're able to, according to the vent at least. And so don't be surprised if your ventilator starts alarming a lot. The other thing that we want to do is we want to assess what their respiratory rate was before we intubated them so that we can mimic that on the vent. So we should never see a vent, ever see a vent on a DKA patient that's set at a rate of 12 with a volume of 450 or 500, because that's how these patients die. So we want to make sure that we mimic what the body was doing. So if their respiratory rate was 40 before we intubated them, then while that seems like a crazy high number, their rate on that vent should be 40. And we want to make sure that, like with any ventilated patient, we get a height so we can accurately determine their mLs per kilo for their tidal volume, because you don't want to assume based off of somebody's body habitus. I have a really good photo I should share with you guys later. It's an x-ray of somebody that's obese, but looks like they would have pretty large lung volumes based off of their external imaging, right? But then when you look at the actual x-ray, their lungs are so small. And if you measure their height, you can actually see that it more correlates with that. But we get kind of distorted with looking at a person externally saying, oh, okay, yeah, I'm sure that they can probably handle 500 mLs. And they would actually be closer to 350 mLs if we did 6 mLs per kilo or 7 mLs per kilo. We want to make sure that we get an accurate number there. And then, we have to recognize that our minute ventilation is going to be really high. So our minute ventilation is our tidal volume times our respiratory rate. So that's how many liters per minute of air we're moving. And, normal people might be 4 to 6, maybe 8 liters per minute, especially if you're just kind of resting, you're not ill, you're not acidotic. These people could be 15, 20. I mean, it can get really high because you're wanting to blow off as much CO2 as we can to try and help to get that acidosis down and keep it at a point where the body's able to still kind of function even in an acidotic state. And then you talk about the end tidal and your CO2, right? So we have to recognize that our opening end tidal might be low. So we're traditionally taught that 30 to 35 for an end tidal is normal. You intubate somebody, you put them on end tidal, 30 to 35 is roughly what you should see. Well, because this is such a bad metabolic acidosis and your patient's blowing off more CO2 than would be considered normal to try to prevent systemic collapse, you might have a patient that gets intubated and you see that their opening end tidals, say 20, right? That means that they've been blowing off to maintain an end tidal of about 20, and that's been working for them in this severe acidotic state. So that means that we should probably target an end tidal of 20. That does not mean that you say, oh, well, 20 is really low. We want to get them back to normal of 30 to 35. Normal in these patients kills these patients. So if we see that somebody has a lower end tidal when we first intubate them, and that's after whatever pause it took to get them intubated in the first place, which we want to minimize as much as possible. So we just want to make sure that we keep that number roughly where it was. We don't want to allow it to get to normal because that just means that the CO2 is going to rise and that acidosis is going to get worse. It's a really hard concept to get because it's not really like any other patients that we tend to see. The metabolic derangement in these patients is so severe that their vent management is really particular. And so it can be really hard if you haven't seen it in a patient, manage a patient like this. So just kind of keep these pieces in mind. You want to help to support them in their compensatory mechanism of blowing off as much as possible. And a lot of times you'll hear, a patient comes in and they're like, oh, I think they're in DKA because their blood sugar's high and you don't have anything else pre-hospitally to support you when it comes to labs or urinalysis or anything like that. But there's another potential it could be, and that's HHNS. So I don't know if I'm dating myself, but when I was in school, this was HHNK, but it's HHNS now. So that's hyperglycemic, hyperosmolar, non-ketotic syndrome. And it's another serious condition, but it's more commonly seen in patients with type 2 diabetes instead of type 1. So DKA is more type 1, HHNS is more type 2. And in this disorder, you actually tend to see higher blood sugars in general and worse dehydration. So the basic issue is that there's a lack of effective insulin. So there's that buildup, there's an insulin resistance rather than a lack of insulin like in DKA. And so when there's a lack of effective insulin, it puts the patient in a hyperglycemic state. And that persistent state causes osmotic diuresis, like we talked about a little bit earlier. Remember how water follows the glucose and other electrolytes get spilled into the urine. So same thing happens here. And that's the hyperosmolar part. And then to try to fix the main problem, the body starts shifting water from inside the cell to outside the cell into the vascular space. Obviously, it causes dehydration in the cell because now they've given up all their good fluid, right? And that causes symptoms such as decreased mentation. And so you can see signs of dehydration, low blood pressure, high heart rate. You remember how in DKA we have an increase in ketones because the body can't use any of the glucose. We don't have that in HHNS. We also typically don't have an elevated anion gap here either. However, the treatment is fairly similar. You want to correct the fluid imbalance. You want to give the electrolytes. You want to give insulin. But in HHNS, at least, the insulin's a little less of an important part because it's not needed to reverse the acidosis because there's not really an acidosis as much in this condition as there is in DKA with a really severe acidosis. And that's what that insulin helps with the DKA, right? Is trying to reverse the amount of ketones in the body, which decreases the amount of acid. In HHNS, it's really more of a dehydration problem that really becomes the issue. So I threw this in here just as a potential. It's not always DKA, especially if your patient is a type 2 diabetic. And if they're a type 2 diabetic and they have a really high blood sugar and they're exhibiting a lot of the symptoms, while the treatment's fairly similar, just keep in mind that they may end up needing a little bit more fluid because they tend to be a little bit more dehydrated than your DKA patients. But your DKA patients are really sick patients. They can be really kind of scary when you first see them, because a lot of times when they're severe, they're lethargic, they can't answer you, their vitals are, high heart rate, low blood pressure, you're not entirely sure what's going on. Then you start going down the path once you check that blood sugar and you see that there's something wrong there. And then you kind of start this whole process with your treatment and interpretation. So are there any questions?